to thank the organization committee for this opportunity to present on the state of the art of endovascular stroke therapy. You're going to talk a little bit about the past, the present, and then the future of this therapy. Here are my disclosures. So it turns out that the inception of endovascular stroke therapy dates back from the late 1950s and actually predates the coronary intervention by over 2 decades. However, you had a tough start. We initially had trials that were mostly involving intraarterial thrombolytics and the early devices, the early mechanical device called the Mercy corkscrew device. And unfortunately, these trials were negative. In 2013, you had 3 negative trials published at the New England Journal of Medicine. However, this gave us the opportunity to step back and plan things better because you could finally understand that you had to select the patient population better, really understand who are the patients that have an occlusion, a high clinical deficit, a small stroke burden. So they have enough soluble brain, but not only that, we need better tools. And we had then some clinical trials that allow for us to prove that better tools that were specifically designed to deal with these more complex occlusions actually had better outcomes than the early tool, the Mercy device. And those were the SWIFT trial and the TrivoShoe trial. Well, with the right tools in place, you could then perform the second generation trials involving the stent retriever technology. And we start with the early window trials. By early window, we typically mean 0 to 6 hours, although some of these trials have treated patients up to 8 or even 12 hours, but the bulk of them, it's 0 to 6 hours. And here are them. There were the MistraClean trial, the SCAPE trial, Extend IA, SWIFT Prime, Revascat, Trace, and more recent, Resilient in Latin America. So a very broad distribution across the globe. But they all show the same thing. They demonstrate that by using the stent retriever technology and performing thrombectomy in these patients, we could achieve better outcomes than the medical group, which actually include intravenous thrombolysis in all these trials and in the vast majority of the patients, over 3/4 of them. And what you can see here is a shift, okay, towards better degrees of functional capacity at 90 days. This is so-called the modified Monk scale, where you go from 0, essentially being normal, to minor disability, to maybe some disability, but still functionally being completely independent at 90 days, to being able to walk without any assistance, then having in the number 4 here, some more moderate to severe disability. 5 is essentially bad reading with severe disability, and 6 is death. Okay, but by treating the patients with thrombectomy, you shift again from the higher degree of disability to the lower degree of disability. And we now have the so-called Hermes meta-analysis, which essentially at an individual patient level pull the data from all these trials to kind of in a broader manner quantify the benefit of this treatment. And it turns out that if you have thrombectomy, you have 2.5 times higher chances of having at least 1 point lower disability across the scale. Not only that, but if you have thrombectomy, you have 2.7 higher chances of having functional independence at 90 days versus not having the treatment. This is actually achieved at a broad range of patients' characteristics, differences in age, in the amount of stroke burden, the so-called aspect scale, the autoplays used versus not intravenously, the location of the stroke in the proximal anterior circulation, the range of the NIH stroke scale score, time to randomization, sex, and the presence or not of tandem cervical occlusion. So how these patients, you can see here, they pretty much benefit from the intervention. And when you look at other imaging characteristics like the collateral grade, the amount of clot in the brain, whether or not the patient had a large stroke or not, you again see that how these patients seem to benefit from treatment. In fact, you haven't not yet fully identified a subset of patients that are not benefit from this. So after you conquer the early window, we could then work on the late window trials. This actually started kind of in parallel, slightly delayed, and there were 2 major trials, the DAWN trial 6 to 24 hours, and the diffuse 3 trials, 6 to 16 hours, that actually proved there was a benefit. Very much like you had the Hermes analysis in the 0 to 6 hours, you had the Aurora analysis in the 6 to 24 hours. Not only competing down in diffuse 3, but also all the other trials that treated beyond 6 hours. So you got all those patients and put in this analysis. And here you can demonstrate that as long as you have a favorable clinical imaging profile maintained in the late window, you can achieve similar safety with no increase in the rates of symptomatic intracranial hemorrhage, at least significantly, which is very much what you have in terms of symptomatic intracranial hemorrhage in the early window. So it's very safe treatment, thrombectomy. Not only that, but mortality, it's numerically low, although not statistically significant, which is the same thing you see in the early window. Well, what was very nice to see is that as long as you keep, again, this favorable clinical imaging profile, meaning a high NIH stroke scale with a small stroke, or you have a perfusion deficit in the late window, you're gonna benefit from this treatment. To the point that the number of patients you need to treat in order to have 1 point decrease along of the disability scale was just 2.5 patients. Just to put this in perspective, for antibiotics to help somebody with sepsis or septic shock, the number needed to treat is 4. This is actually similar to that. It's pretty remarkable. And when you look at the overall efficacy here in terms of the odds ratio of the chances, okay, you are 2.8 times more likely to have any degree of disability improvement with thrombectomy in the late window, which is similar to the 2.5 we described in the early window. Obviously, these remarkable findings led to changes in the treatment guidelines. And this came in 2015, then we're revising in 18 and then 19. And essentially, we know now that you should be treating the patients that have good clinical status in terms of functional characteristics in MRS 0 to 1 and have an intracranial ICA or an MCA M1 occlusion, so long as they have the 666 NIH stroke scale equal or greater than 6, aspects equal or greater than 6, presenting within the first 6 hours. This was initially applicable to stent retrievers, but now you have trials demonstrate that the direct aspiration technology might be just as good. Okay. Having said that, if the patients are candidates for TPA, even though there are trials now that are evaluating this, at this point in time, you should give TPA for those patients, but you should not wait to do the thrombectomy. You do the bridging approach where you treat and you immediately perform the thrombectomy as soon as you can. Technique at the place is something, TNK, that seems very, very promising in this patient population, okay? And finally, you should not necessarily rely on fancy studies like perfusion MRI to select these patients. There are areas of uncertainty. We're going to talk very briefly about some of them. 6 to 24-hour window, we still need advanced imaging. But here are some of the new frontiers, right? We have the capability of potentially expanding this treatment in patients with low clinical severity, large stroke, basal artery occlusions, distal medial occlusions. And also you can improve mechanical thrombectomy by either removing lytics early on or adding lytics later or coming up with better lytics or simplifying selection paradigms, as well as incorporating neuroprotection, including cooling or collateral flow augmentation strategies. So there are several patients that present with a large vessel occlusion but have a low NIH stroke scale. And there is a lot of controversy right now. We don't know what to do, but there are essentially 3 randomized clinical trials looking at the situation, Tempo 2 with intravenous thrombolysis, endo-low, and in extremis mostly with endovascular therapy. Large vessel with large cores, meaning aspects 0 to 5 or cores that are greater than 70 cc's, they seem to benefit, at least the aspects 3 to 5 in the Hermes meta-analysis, maybe even the cores greater than 7, you see here no safety concerns with increasing hemorrhage, in fact, numerically lower in thrombectomy than in control. So it's an area that you are exploring, very good single center and retrospective data, and you have several trials ongoing right now. Basal artery occlusion have 2 trials, BEST and BASICS. Unfortunately, they had methodological issues, poor recruitment, but when you did a pool analysis called the Veritas pool analysis, and we specified the patients with NIH stroke scale equal greater than 10. It seems that thrombectomy has a 2 times higher chances of causing improvement in these patients when you define an MRS of 0 to 3 at 90 days, despite an expected increase in the rates of intracranial hemorrhage. Distal medial occlusions, we still don't know what to do to many of these patients, but I think the M2, at least the proximal dominant M2, we know we should be treating them. I think for the smaller M2s, M3s, M4s, ACAs, and PCAs, we still need more data. It is very important, though, that you understand a lot of these things are relative, and that's not what matters to patients. Here is an example, a distal occlusion outside the guidelines, a low NIH outside the guidelines, but a high clinical disability, a patient with NIH of 5 with leg plegia, that's 4 points, okay, just 4 points. But if you can't walk at 90 days, you're gonna have an MRS of 4. So despite the distal occlusion, okay, we should treat these patients aggressively and rescue the ischemic brain to improve their clinical capacity, because here is the truth. Patients do not care about their site of occlusion, about their number of the NIH. They don't even know what those things are. What they care about is the degree of disability that they will have to cope for the rest of their lives if we don't reperfuse the suffering tissue. And here is an area where you need to incorporate a so-called precision medicine, individualize the care of these patients. It's important that you understand the outcomes. They are irreversibly proportional to 3 main factors: final infarct volume, but also the location, the eloquence of the infarcted tissue, and the biological age of the patient. And obviously, final infarct volumes, yes, they grow over time, but collaterals buys you time. So incorporate all these things in the decision-making of each patient. And we live on a sad reality of nihilistic-based medicine. Let's just compare our field with other fields, right? How often patients are excluded from the treatment due to poor prognosis or treatment costs in MI, okay, or sepsis, for instance. Like the cardiogenic shock has a mortality of 40%. Okay, septic shock has a mortality of 40%. Trauma has very high mortality. You invest everything in these patients. Treatment of cancer is very, very expensive, just to buy sometimes few months, right? But you invest a lot in these patients. And here is the reality. When you don't treat these conditions, ST elevation, MI, sepsis, trauma, and cancer, most of the time these patients, they die. When you don't treat a large vessel occlusion stroke, most of the time these patients don't die. They actually live with severe functional disability. When these patients die, there is actually no financial burden to society anymore. When you are alive with severe disability, you are actually a big societal burden, including financial one. So if anything, you should be more aggressive with stroke than other conditions. So what I would say is that all shocks should be treated equally. Cardiogenic and septic shock, we treat patients aggressively despite the worst prognosis and higher mortality. Why? Because there is still a treatment effect. You don't treat patients in these conditions according to predictors of outcome, but rather treatment effect modifiers. So you treat them aggressively. However, the patient that shows with a large stroke, we don't treat. Maybe they don't generate the same degree of empathy. You know, it's not such a dramatic picture. Maybe you need to change the name to cerebral ischemic shock to trigger a better response. So in conclusion, EVT in acute ischemic stroke has one of the largest treatment effects in medicine. However, this may be the product of over-selection leading to no treatment or under-treatment in many patients that could still benefit. There are likely much more patients being harmed by no treatment than treatment in both early and treatment windows in this paradigm. So my final message is select faster, select less, and treat more. Thank you for your attention.